Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAXscope. Thank you for joining me in my latest video using the WAXscope and very difficult, challenging ear. So this patient attended with a blocked right ear, and as you can probably see, they've got a very narrow ear canal entrance. In fact, their canal entrance is what we call collapsed, and part of the reason for that is the last time I saw this patient was, I think, a couple of years ago. They had a suspected lesion on their auricle, which is, so the auricle is another name given to the pinna, which is the satellite dish that we have on either side of our heads, and they had basal cell carcinoma and quite a big ulceration, and they were undergoing treatment for that, so they had some radiotherapy. But when they attended last week, the outer ear, the auricle, is completely plastered, and the patient advised that they've actually got a hole that's gone right through their auricle, and they're still is still under the correct care, and they might need to have surgery. Well, I think they are going to have surgery. So I couldn't see it myself because it was all covered in bandages and plaster, and but that since the last time I saw this patient, this ear has really collapsed at the entrance, so that auricle pinna is kind of flopped over, and it just made it more difficult, this procedure. And they have got some fungal overgrowth there, so you can see some hyphae, so some aspergillus likely sitting on the surface. This is dead skin. This is all dead skin, and it was really deep, really impacted. This patient does wear a hearing aid as well. I'm not sure, well, at the moment they're not wearing the hearing aid because the ear is plastered, but previously there were. And so I think in part this has impacted this dead skin, but patients who undergo radiotherapy around the ears, so this patient would obviously be one of those, they can start having a buildup of dead skin and really dry skin because the radiotherapy damages, kills blood vessels, which help to promote the epithelial migration. So this skin that lines the ear canal and the outermost layer of the eardrum, the cuticular stratum, it's fueled by blood flow. So in the absence or reduced blood flow, you're more likely to have a collection of dead skin, and the ear becomes dry because all the sebaceous glands, ceruminous glands, they're also damaged as a result of the radiotherapy, so they have natural less secretions of sebum, which is an oily lipid secretion, and also an oily sweat produced by the ceruminous glands, which are modified apocrine glands. So it made it really, really difficult, and again, I wanted to challenge myself by using the WAXscope, but the WAXscope really helped because it helped to stretch the ear open as much as possible. So I've just put some oil in here just because there's no other way this is going to come away. It's really dry and embedded, and you've seen me use the right angled ear hook. It kind of just dissected it, didn't remove it, but even by breaking it up into smaller pieces, it does facilitate the removal. And you can see that skin there, you can see the ripple effect on there at the base. And I'm going to use the forceps as well, but what was really, really tricky, and what's amazing, once we remove this, you'll have a fantastic view of the eardrum, which initially I thought I probably wouldn't get because of how narrow the ear is. So I'm just using the left-hand side of the specular to open up that first bend as much as possible, but the canal has collapsed obviously a bit deeper as well there. So here's me using the forceps. Again, I think, there needs to be a slightly new design of forceps, and I know some of you watching have kind of advised that and given some suggestions as well, because with this type of skin, it's really difficult to grab onto. I mean, you can get Henkel forceps, which are almost like a hippo's mouth, so there's no serrated edges. It does work quite well, but the ones currently are just really, really big. You can get some micro ones, but they're still a bit bigger than I would ideally like. And in the case of this narrow, the standard Henkel forceps, and I've got a few at the clinic, it just wouldn't go into this patient's ear. So what I'm doing, I'm really trying to leverage the skin away. It's attached at the top and on the front part of the ear canal. And when we peel this away from the anterior canal wall, you will see a bit of blistering. I did pre-warn the patient that they may get a bit of blistering just because of how adherent this was. I'm just trying to pull it down, and you will get a view of the skin deep in the ear being peeled away off the eardrum and from the canal wall. So I'm just leveraging it down. So I've more or less detached that section, and now we're going to try and pull it away. And again, you get a good level of detail on the texture of the skin. All these dead skin cells, they're interlocked, so they haven't detached from one another, which when the skin naturally migrates from the eardrum towards the entrance, as it approaches the entrance, the individual skin cells, they begin to detach and flake away. So we call that desquamous skin, when they actually detach from one another and off the set of the canal wall. So these individual skin cells still have that lamellar structure, they're interlocked. So just getting just peeling a ribbon of skin here. Again, I'm just going to stretch the ear open. Just the reflections, just because the skin is highly reflective. It contains a lot of keratin, which is a protein that's also found in our fingernails and hairs, and it reflects light very well. One of the functions actually is to help repel harmful UV sun rays from the sun. Now, some of the eardrum is appearing posteriorly. So to fellow specialists, if you're watching, so the speculum that we're using is actually a really, really small speculum, 3.5 millimeter. But because of that Tumarkin slot that you can see, that opening where we insert the instrument through, it allows you to visualize even in really, really narrow ears and have both the dead skin in this case, but obviously if there's wax, and the instrument in full view. Quite often when and I'm using a full Zollner suction probe, by the way. This is not a fine end. This is a 14 gauge suction probe. Quite often when you use a small specular like this, and the instrument, because the instrument has to go through the center of the speculum, or it has to enter through the specular, there's no opening, the instrument can impede the view of the wax or skin, so that's somewhat overcome by having the Tumarkin slot. Probably say the only negative of having a Tumarkin slot is that if you've got a patient with really, really long hairs, they sometimes can enter through that slot. However, when you insert the instrument through the slot, it kind of pushes it away somewhat, just similarly to how a fully rounded speculum does. So it's not a major issue. You can see here, this is where the skin's really adherent, and as I'm peeling it away, it just blister a little, somewhat. So I'm just really tugging it and pulling it down. And if you look in the background, probably about 2 o'clock, as I'm pulling the skin, you can see it starting to peel away from the side canal walls. The eardrum is slowly revealing itself. There we are, slowly coming away. I think I do still use the forceps in a moment, which we'll see. I'm just using these little tug movements to separate the skin and then slowly bring it forwards. Probably got a good view there, the canal collapsing when I remove the specular. I think this patient's got an upcoming appointment to see a specialist about the ulceration in the ear. So it's good just to have this ear cleaned beforehand. So I've got slightly a better grip now. You can just see how thick that blanket of skin is. So I separate some skin there. It's going to widen the ear. So some of the skin has become brought forward, as you can see. So this is just past the second bend. I'm just using a different angle with the forceps to bring it through. In an ideal world, when you grab onto this skin and you start pulling it, you want it to come out in a big plug, but seldom does that happen, unfortunately. And there's another layer of skin. So the lighter the colour of the skin, the sheets of skin, the fresher that skin is the darker the skin, the longer it's been shed and remained in the ear, so it kind of goes through an oxidization process. And it darkens. So this is more on the floor of the ear canal. I'm using a slightly different angle. Well, it appears that way, but I just think it was the way the patient was positioned. Their head was drooping forwards a little bit, so actually the angle of the speculum is as I would normally use. You can see the opening is more at the top part of the ear canal. So because this patient's head's drooped forwards, the top of the ear canal is actually about about 2 o'clock. There you can see the hyphae a little bit more on the surface of the skin. Again, I'm just going to stretch the ear open. See that level of detail that we've got. I think the skin's just attached to the left-hand side canal wall, so I'm just going to try and peel it away there. So I suspect some people won't enjoy the video because of the view, but this is what we have to encounter in clinic, and of course with an endoscope. Now, this is why we actually developed the WAXscope, because a lot of specialists with an endoscope will struggle to open this ear up. Because when you use an endoscope, for those specialists that are really competent with it, it's not much of an issue, but it is a difficult skill using an endoscope, and in the absence of the specular, there's no way you'll be able to get that suction probe in because the ear canal's collapsed. So with the specular, we're opening up the ear as much as possible, and with an endoscope, there is no specular. I mean, you can get endoscopes with specular attachments, but they're not therapeutic, what we call therapeutic specular, where you can pass instruments through. So with the endoscope, you'd have to, in this case, which is the patient's right ear, when I insert the endoscope, I'll have to use the left-hand side of the endoscope to push that flesh, that cartilage to the left to open up the ear. So I'm just going to visualise the eardrum. As you can see, we've got a fantastic view of the eardrum. So it's just more the outer third of the ear canal that's quite narrow, the cartilaginous portion. You can see that blister in there. That was fine. Patient didn't feel it, but as I said, I did pre-warn them. Now they've still got this blanket of dead skin at the bottom. I'm going to just try and peel as much away as possible. And now I'm using the fine end. So you can see the difference in suction probe size. I'm just lifting this up. And I'm just going to give it a wriggle left to right because it's attached on either side. And kind of want to keep the suction probe attached as long as possible. You don't want to lose the grip because that's when it can possibly clarinet. So want to avoid clarinet. Clarineting is when you suction dead skin, the skin can violently flap and it emits a very loud high frequency squeal. It's not only loud for the patient, it's loud for myself as well. So you just want a good suction grip, and there we are. There's a bit more skin left, so we're just going to try to peel a bit more away. The more skin we get away, because there is some fungal growth there. So the patient will need some antifungal treatment. But if we can remove the dead skin. Now, one of the functions of the skin migrating is to expel any harmful bacterial fungus that on the skin. If that skin was constantly there, then if you've got any pathogenic bacterial fungus, it gives it more of an opportunity to colonize and really lead to an infection and become pathogenic. But one of the benefits of the skin naturally migrating, it does expel any harmful bacterial fungus that's on there, on the surface. There we are. So there's a few flakes, but you're not going to have to get everything. Just going to re-enter. Stretch that ear open as much as I can. So you can see you've got a good view of the eardrum there. Well, I hope you enjoyed that video, guys. Do take care, keep well, and speak soon. Bye.